Welcome to Seminar 2 from North Coast Vets, and I hope we can provide some entertainment, albeit lighthearted tonight for you. My seminar tonight is to talk about what I do and what my process is when I see an X-ray to review. We see a ton of X-rays that come every single day, and very grateful for you guys for sending them, but from many different sources and very, very varying quality, from awesome to always even more awesome. Thank you for sending them. But it's important to sort of take home some tips that I can maybe give you, show you some cases that I've seen from you over the years, some of the stuff that we see, and make this a structured exercise in how we do it. This is very much a pictorial review tonight. There's lots of slides of different things, but we'll give you some structure as to how I like to think about an X-ray. And again, hopefully you can take one message home. So we know that X-rays are done the world over, and there's a ton of different things we use X-rays for. And I know with modern technology, there's more advanced imaging that has come into play over the years, and many of us don't have it available, but I would also say that a good quality X-ray goes a hell of a long way to getting you on the path to diagnoses. It's not often in the fields that we all do that we need advanced imaging. To me, having a good X-ray will go a long way. Sometimes our hands are tied and we have no choice. This is a surfer that broke his pelvis, sorry. So this is obviously a swab that's left in. This is a total hip replacement. So X-rays are used for a ton of different things, and they provide valuable information to us all. To me, an X-ray is nothing without clinical presentation, and it's often what I think maybe gets forgotten to a point. Sometimes our hands are tied and we have no choice but to take a dog or a catagram, for example, when we're dealing with trauma cases. A very valuable thing to do, but to me, the art and some of the X-rays that we see is, I've got an X-ray here, but I can't localize the lameness, or I can't find anything. That's not a bad thing, because we're in a search for answers, but being precise and as much as possible in our localization is very, very important. And I'll show you a few things as we go through, because it's very easy to make a wrong diagnosis and be led down the wrong path. And it's important to see even some of the more common things, and I'm going to try and make this talk about common things, that we see in practice, as well as some of the things that we see that can help our diagnostics. So an example here is a plantar rupture, rupture of the Achilles tendon up here, followed on by radiographs to me that show that we have an Achilles tendon rupture. Rich, there we go. Where's it gone? Oh, there we go. So we've got swelling around the Achilles tendon here again, fits with the clinical localization. That's an easy thing to find. Sometimes it's not so bad. To me, and probably the biggest question I will always ask, and I'm going to harp on about this tonight, is that radiographs should correlate with clinical signs. This is a pelvis that was taken. Obviously, you can see that there is hip arthritis there. We can all see that. This dog had never had a day's lameness in his hip in his life that we knew of. But when we look at his knee, and I'll explain what all this, the radiographic signs that we see. This dog's got cruciate disease. Again, probably one of the most common scenarios that we see in practice is a dog comes in with hip X-rays. Our first question that we should ask is, in the right breed, the right age of dog, what are its knees like? And I reckon it's over 50% of dogs, probably even higher, that have cruciate disease in the right. The 1-2-year-old bull Arab, for example, comes in with hip arthritis that they all have anyhow. Not all of them, but most of them. Most of them have cruciate disease in some way, shape or form, and it can mimic the same thing. So again, just a very important thing to look for. Radiographs don't always correlate with clinical signs. So it's important that we use our clinical skills, we hone our skills that we've learned. Sometimes though, and I had to put this slide up, they do correlate with clinical signs. So a squirrel, that's all I'll say, and go no more. So the one video I've put up here, you'll see that. I want you to go and have a look at that on YouTube, okay? I'll say no more. I'd love to hear your feedback on it. If it doesn't make you laugh, there's something wrong. And it's written down for you. So, but yeah, have a look at it. So, okay, so the principles of diagnostic radiography. To me, having a good X-ray improves your diagnostic ability. An X-ray that comes in that's it's not lined up properly, and I'll show you again, is often missed. When you're looking at an X-ray is not just a bone. An X-ray is soft tissues. All bones respond to the presence of soft tissues around them. And so changes in the soft tissues, reflection in the soft tissues, whether it be atrophy or muscle mass loss, tearing of a muscle on a bone, they're going to produce a bony reaction. But bones are made and developed, and the mechanics work by soft tissues. So we're looking at both. So it's important that you have soft tissue balance in your X-rays rather than coning down to just have a soft tissue, just having a bone. For example, joint effusion in a dog or a cat that you're looking at or whatever. Joint effusion can be subtly missed if you cone down too far to look at the bones alone. Very easy to miss the soft tissue density inside a joint. And we commonly see X-rays in that respect. You've got a very nice bone shadow, but if you lose that soft tissue, there's things that we miss along the way, potentially. X-rays should be collimated. So I'll just get this all working in. X-rays should be two planes. Now, this is not correct, even though it is two planes. Ideally, if I've got a collimated X-ray of a femur, say I'm worried about a femur, I would have a collimated X-ray of the femur alone. I wouldn't use the pelvis, and again, I didn't have room to put this in, but I would have a single femur with a 90-degree, called an orthogonal view of the other femur. The perfect example of this is iliopsoas tendinopathy. See this little piece of bone here off the lesser trochanter? That is not seen on here. Clinically, this patient had pain in the hip, thinking arthritis in the hip and a working Kelpie. We know that iliopsoas tendinopathy is reasonably common. Again, this little piece of bone can be an important pointer that on a single view is missed. So appropriate orthogonal views are critical for any diagnosis. X-rays should be lined up in their plane. I'm going to run through how we line them up soon. And the other thing I'm going to say is always use, where you can, a comparison of the other side. This is an example of a cat with metaphyseal osteopathy or femoral capital physeal slippage. Again, often bilateral, but until we look at the other side, we don't see that. Again, it's important that we use the comparison. When you've got both are gone, it can be hard, but when you have a normal other leg or another part of the body, it can help. So consider looking at both, use them as your comparisons. For fractures example, use the other leg, use it as your template to line things up. So try to radiograph the area of interest where you can, as we talked about. The other thing to keep in mind is that radiographs are anatomy. This is an anatomical picture we're looking at. Everything is connected to a bone, to a soft tissue. So have a working knowledge of anatomy, what could be in that area. Open the anatomy book, get an idea of what's going on once you've localized where your lameness is. And don't get me wrong, lamenesses can be hard to localize. We all struggle with some dogs, the roddy that comes in like this, and it has to be an osteosarc or an elbow or a septic joint. You can't find, you CT them, you can't find what's going on. 3 weeks later he's better, and you know better off, and I remember that case well. So it can be very, very hard. Don't look at the X-rays first. That's probably my first take-home message. An X-ray comes in, don't even think about it. If a client comes in or you're thinking about taking an X-ray, don't even think about taking an X-ray till you've got an idea of where the localization is. And it probably more applies to me because we get X-rays coming through from email. The temptation is to look at the X-rays and say, oh, it's got to be that, and it often is. But again, take a step back, clinically localize this case, do a normal exam, right from history, physical exam, signalment, because it's so important. Common things occur commonly, very, very commonly. The 9-month-old border collie, lame in the forelimbs, it's OCD of the shoulder to proven otherwise. Secondly, it's probably elbows. Thirdly, it's probably sesamoids. And you're usually right at the end of the day. So common things occur commonly. The 1-year-old bull Arab with hind limb lameness is going to be hip dysplasia. It's going to be stifle disease, cruciate disease. The German Shepherd, the 6-month-old, they've all got panosteitis, till proven otherwise. I reckon every German Shepherd gets panosteitis. Not many of them are that lame from it, but when they're lame, they are lame. So they've all got panosteitis if they're a German Shepherd under a year of age. Just keep an eye when you're saying, well, maybe he's got elbow dysplasia because they get ununited ankylosing process, for example. When you're squeezing on the forearm to twist the elbow and extend the elbow and he's hurting, is it the elbow or is it the panosteitis that you're squeezing on? So just keep in mind that common things occur very commonly and they repeat. They really do. In this case here, as I said, a dog comes in with hip dysplasia, for example, and he's got a tumour of his toe. So look at the feet, look at the toes, sesamoiditis, OA of joints, they all occur very commonly. So always look at the whole limb when you're doing your clinical exam. As I said, I can't give you a talk on radiography without going into individual cases and talking about diseases that occur in certain breeds because they're all tied in. Always look on the edge of the film. Don't forget the edge of the film, and part of the scrutiny of these films is look on the edge. As an example with disco. So discospondylitis occurs. You miss these things. They present as lameness, they present as back pain. Look on the edge of the film. We're back again. Again, a shoulder here, for example, with a flattening of the caudal aspect of the humeral head. I'll explain positioning in a second to help you, is consistent with the humeral OCD. But this doggy also has a coronoid fissure in here. As I said, I'll explain how we pick those up. This is sclerosis, but I'll talk about shortly. A dog with knee lameness here. This dog has no effusion sitting inside the joint here, this nice black triangle, but he has damage to the gastrocnemius tendon on the back of the knee. So again, just even when you're looking at a single joint, go through the individual bones, check the accessory carpal in the wrist, for example, palpate all the bones individually, observation for swelling, check the ligaments. So it's all anatomy at the end of the day. And as I said, if there's books that tell us how to test these individual joints, and it's very much worthwhile thinking about it. This is a case of metaphyseal osteopathy, 6-month-old Great Dane with swelling around the joint itself. If you see that, it's pathognomonic. That's our that's our ghost physis, or second physeal line that we see in hypertrophic osteodystrophy, metaphyseal osteopathy, same thing. Moving on. So when I look at an X-ray, there's a few things I look at. I look at the quality of the film. I say to myself, well, can I see soft tissue? Can I see bone? Are they in reasonable quality? So I look and I say, can I potentially make an observation from this? Can I, in a cursory view, see anything obvious? I don't stop there. I just pick out major features and then I take a step back. And it's done very automatically after a while. And then I start looking through individual things. I start at the top and I work down the bones, for example. So say my technique is to, I've got a spine, for example. I look at the soft tissues, I look at the individual alignment of the bones, I look at the disc spaces, I then look at the ribs, I look at the soft tissue. So I have a system that works and I do it every single time. And then repeat this and go from the bottom back. And the worst thing I want is to look at an X-ray and think, oh, it's that, and I send it away to a client. And they come back and say, did you see that fracture there? No, I missed it. So, and I don't ever want to miss anything. We do, but you send them to me to give you a report. But the same system with you guys applies. Be very consistent all the way through. Find a system, even if you go from the corner down, look at every part of it. Look at the alignment. Again, mechanically, the foot and the shoulder should be roughly underneath each other. The joint line of front and back legs, so the spatial alignment needs to be parallel to each other, otherwise you end up with a deformity or a deviation. So part of the normal mechanics is having spatial alignment of the joint. I look at the cortices, I look at straight down here, and I've got a comparison here to say, well, okay, these are normal thickening of the cortices, there's no osteopenia, there's no medullary thinning. I look at the joints here. This is slow. And I say to myself, well, are these joints spatially aligned? Obviously, this is a young dog, so we've got growth plates that are open. Are the growth plates in the joints themselves spatially aligned? So if I look at that joint there and this joint down here, they're not spatially aligned, so that's why we've got a valgus deformity in this dog. Is this a normal side here that I can use? I've still got a spatial or malalignment here. It's not as bad, but to me this is a bilateral deformity. So I look at, and I'm thinking to myself, these are growth plates. This is a young dog. What potential diseases, what conditions am I seeing that would tie in with my clinical exam in a young dog? What's going to cause it? Is it a congenital thing? Is it a developmental thing, an osteochondrosis? Is it a growth plate fracture? Is it a fasciitis, an osteomyelitis? So I'm still always referring back to my clinical picture. What breed have I got? What age have I got? What's he been doing? Where's he lame? Is he shifting lameness? Is he fracture lame? Is he non-weight bearing? Is he an old Maltese, for example, that's non-weight bearing, for example, and he's got a bit of shoulder pain, but he's neurologically abnormal as well. I can't see anything on the x-rays. 10-year-old Maltese, I'm going into his armpit straight away. With a non-weight bearing lameness, he's either got if he's not orthopaedically lame, I'm going for a disc or I'm going for a peripheral nerve sheath tumour. So I'm not saying it's going to be that, but this is on my mind of what I'm thinking, purely based on breed, age, signalement. So, as I said, common things do occur commonly, and they often present lame. A nerve sheath tumour will often be non-weight bearing lame. It looks orthopaedically lame, but we've ruled out a septic shoulder, for example, because he had shoulder pain. Remember too, just to digress, the arthritic joint is very prone to being septic. So, 10, 12-year-old dog with arthritis of the hips, we see septic joints, and it's a cause of lameness. So it's worth getting used to tapping joints. Arthrocentesis of joints is an extremely useful thing and an easy thing to do that often will give you diagnostic yield. Sometimes it doesn't. The absence of normal joint fluid does not exclude disease would be the other thing. So use your clinical judgment on that. So check again, soft tissues and attachments, as we showed you before with that ilias, for example. This is a malformation here. This is we call a type 3 elbow luxation, whereby the ulnar and the radial head is luxated. This dog came and, as we said, his leg needs to be straight. So this was straight up here, but then his lower limb was twisted around like this, as one Craig did. So straight away I'm saying, well, the alignment's not right, the spatial alignment's not right, this is a young puppy, what could be going on? He had a lump on the side of his elbow here, and again, type 3, which is the radial head and the ulnar luxated. So you start to get a picture, but it's always based back to the clinical signs. This is a dog that had tightrope surgery. Once I get this up here, again, I'll show you what I want to see in a minute in the bone responses. But again, this is a dog that's not doing well. We've got fluffiness of the bone here. We've got widening of where the bone tunnel was placed through. And we've got lysis or lucency around the implants here. This was a septic joint. So again, using the history, etc. So always come back to what's going on and the signal in the history. The other thing I'd say is it's worth getting some imaging software. We use this. It's called VPOP. I don't know. Does anyone use it? No. So it's online. It's £12 a month. It's all online. You load it and you load your x-rays up. It's got calibration in there. You can measure your TPLOs. You can measure fractures. If I've got a break here, I can cut this and I can turn the whole bone to be straight again using this software, all online, and then I put my plate on, I select all my plates here, and there's hundreds of implants. I can put my total hip implants in there, anything. It's just beautiful. It's calibrated. You use a marker, which, as I said, I suggest putting a marker on every film, label it, all these things we do anyhow, and you can put everything on here you want to, and then you've got a record of it with all your implants on, and that's an example of a TPLO where we could actually move the plateau down after we'd measured it. We know what blade size we're going to use by this thing here. It's all calibrated. So it's written there. It's called VPOP, but it's a very valuable tool to have. And you've got a permanent record of it as well. And as I said, it's cheap as. It's cheap as chups, mate. But definitely worth getting. So when we think about X-rays, we've only got a limited number of ways that things are going to change. Bone has to respond, soft tissues have to respond. And so if we've got a fair handle on what the bone can do, or what the soft tissues can do, it can help us in our diagnostic journey as to trying to get an answer. And broadly, I've probably missed stuff out, but bone can either increase production, it can decrease production, you can have a mixed response, you can have an increased density of the bone, or you can have a decreased density of the bone. That's probably all it can do. If I got it, if there's a few missing, then okay, that's fine, but that covers most things. So just some easy examples here. And each diseases fit into one of those categories, or for example, an osteosarcoma, something like this here, an osteosarcoma. We have a combination of destruction, we have a combination of production, so we have a mixed pattern going on. We also have, just as an interim, we have this not crossing a joint, so the location and what the biology of this does, it's sitting above the radiocarpal joint. So osteosarcs don't cross the joint. Synovial sarcomas do cross the joint. So you're going to see a variable pattern in that. So again, just these little tips that help. We talked about the septic dog, the septic knee. Again, it's a mixed pattern of lysis, production, and then we're running out of things that actually fit into that pattern of a mixed pattern: infection, neoplasia, some fungal infections. We have panosteitis, the disease we love. These increased medullary densities all the way through the bone in the femur, down in the tibia here, where we've got normal medulla, and then we have these little thumbprint lesions running through. So that's very, very classic for panosteitis. Some of these large bull Araby type dogs, again, this wasn't a shepherd, have these incredibly thin cortices, and you think that's osteopenia. It's not, it's normal for them. Saying that though, looking here with respect to panosteitis, the other thing that you will see is sometimes you see this very smooth medullary infiltrate all the way through the bone, but with a periosteal reaction on the outside. That's still panosteitis. So panosteitis starts like that. It starts as a smooth medullary infiltrate, and then it progresses to the granular infiltrate, more like this scenario up here. So there is a progression in what happens, but the periosteal reaction is the giveaway. If you're not sure if there's a smooth medullary infiltrate, the periosteal reaction is usually the thing that's present in many of these dogs. The bone itself will respond. So look for panosteitis both in your palpation. Think about it, the 6-month-old German Shepherd's coming in. I've got to rule it out. So be careful with your examination, squeezing in the distal humerus, holding the leg to manipulate the elbow. Again, that can elucidate because you're pushing right on the bone. That can be painful. And then you start thinking this is elbow lameness when it's not. So other bone responses that we see, bones can lengthen, bones can deviate. So an example here, a deviation. So we've got a widening of the joint space here, but we have a limb deviation. So the spatial alignment down here is not comparable with the hock joint here. With a history of trauma, putting it all together, tying it together with the clinical features of this. This dog had a tarsometatarsal subluxation, so a traumatic injury. We talked about lengthening and shortening. Again, these brachycephalic chondrodystrophoid dogs have two bones of the four of the antebrachium, the radius and the ulna. So in this case here, we have a long radius, or we have what we call a short ulna. You can call it whatever you like. But a short ulna creates a space here. So instead of having a concentric line between the condyles of the condyle of the humerus and the two bones, we have a gap here. A short ulna predisposes these dogs to ununited anchoneal process because that literally gets pushed off. And so that's the example of a short ulna. This is the treatment. We cut the bone, or we cut it down here. The converse of that, so we can see the change in joint space. The converse here is the opposite, whereby we have a short radius and a long ulna. So we still have this gap in the joint itself. It's not congruent anymore. So it should be a nice circle with concentric lines around. When it's not, there is a discrepancy in the joint. So congruency has changed in that joint. Again, similar thing over here. We have a change in alignment, or we have a deviation in a dog with grade 4, or the highest grade of patellar luxation. You can see this deviation that is obviously present. I would say that it's easy to create with hip x-rays a varus deformity mimicking this sort of problem here. This is real, this can be created, and it's not actually a deformity. So be careful in interpreting that, but when you've got a grade 4 patellar luxation and you've got deviation into this degree and you've got compensatory change in the tibia, trying to put it all in a straight line so it's now becoming a sigmoid shape, then that's likely to be real. So there are some of the responses that we can see with the bone, and there's very few. There's finite responses we can see going on. So I go through the film and as again a cursory overview, I have a look at it, I say to myself, what's the clinical history, what's the sigmoid, etc. I'm using that moving forward, and then I start looking through each of these components. Get an overview first, have an idea of where you're trying to work to. So joints should be spatially aligned, they should be lined up, we should have continuity of joint surfaces. Effusion is another thing that we see, and it's a joint will not be inflamed or will not have an effusion, which is an increase in joint fluid, without something going on with it. Now, a limb that is chronically overloaded could have an effusion, a limb that is septic, neoplastic, inflammatory, ligamentous, whatever will present as an effusion. There's certain joints you see effusion in. There's other joints it's it's impossible to see effusion on an x-ray. The shoulder would be an example of that. You can't see effusion. Stifle, perfect. Elbow, sometimes. Hock, perfect. Digits sometimes. So two big joints, knees that we all see, elbows that we all see. Very common to see effusion. Should I say, more common in the hock than it is in the elbow, but you do see effusion. What we should typically see in the knee, for example, and I'll reiterate this as we go through, we should have a nice triangle of change in shades through the joint itself. Obviously the patellar tendon or the straight patellar tendon is straight. We should also, and one thing to pick up for mild effusion, is we should also have a fascial line right at the back of the joint, running from the caudal aspect of the femoral condyle down to the caudal aspect of the tibial plateau. And in effusion, this will bulge out. So I'll show you a couple shortly. Here's an effusion. Sorry, here. Get this, there we go again. So the hock joint, for example, this is the ankle joint, so this is the talus here. At the back of the joint here, this is where we see effusion, right in this plantaromedial, plantarolateral joint space. Nothing there. See, there's a nice clean line through there. The Achilles tendon is at the back here. I have been drinking, but I haven't been drinking that much that it's affecting my movement. But this is the effusion in the hock itself. So that is what you look for in the ankle joint. You can also see that we're pretty arthritic in there. We've got widening of the joint space here. We've got remodeling. We've got osteophytes forming. And so we've got an arthritic joint with a joint effusion. That was a septic joint. So again, we've identified effusion. We've said, well, okay, this has got to be real. What am I going to do about it? And so my next step with this is not to say this is just arthritis, put a needle in it. And it was septic. So again, one of the treatments for arthritis is to rule out a septic joint because it occurs very often, and in any joint, including toes, including digits. So they do occur. So presence of soft tissue of radiodensities in the joint itself. This is a little greyhound we did yesterday with an avulsion fracture off the medial malleolus here of the tibia. Again, soft tissue swelling around the outside. Again, a history of trauma, pain and lameness in that area. So again, it's still coming back to clinical presentation. So soft tissue is really important, and that's why lining up x-rays is really important. If you can have a comparison between the left and the right with spatially aligned x-rays, it gives you huge pointers. The two best examples I've got here. So this is an example of a dog with hip dysplasia. This is an example of a dog with hip dysplasia with muscle atrophy of the gluteal muscles. So this gluteal musculature here and here is a direct reflection of function of the hip itself. When I have a dog like this, and say I worried about knees, when I've got nice bulky quadriceps muscles here that are symmetrical on both sides, This is nothing distal. A dog with gluteal muscle atrophy but with normal quads has got a hip problem. So we're using the soft tissues to give us an idea of what's going on. And it's very difficult when you see dogs, and you see a lot of them because we have a lot of these Arab breeds, Labradors, Great Danes with knee and hip disease. So it's a matter of deciding which one am I going to treat at the end of the day. In the knee itself, again, extra pointers that I use is the presence of a medial buttress. So with chronic cruciate disease, you develop this soft tissue swelling over the medial aspect of the tibia. That's called our buttress, which we probably know. If I look on this X-ray here, I have fleshy gluteals, and what I do is if I run a line from here roughly down to the trochanter of the femur, that should be almost in a straight line. This here you can see on this side, see how that's bulging out. They are well developed gluteal muscles, whereas if I look at this side here, if I compare the length on a rough, this is not quite straight, but it's for comparison purposes. If I compare that length to that length, we have quads atrophy on that side. That's a knee, that's a stifle of where I'm going to. So the stifle is directly reflected in the bulk of the quadriceps muscle. The hip is directly reflected in the bulk of the gluteal muscles. And it's very reliable, it's repeatable, and it can be used. This is an example of a bony reaction here. Again, when you're looking at these weird forelimb lamenesses, always check the dew claw. The abductor pollicis longus tendon or stenosing tenosynovitis in humans is reflected by changes in the bone here. Pushing on that medial aspect is painful in these dogs with adductor pollicis longus. Border Collie, Kelpies, common breeds that we see it in. Labradors, I'd say, are one other breed that we see it in. So look on that, palpate on that. But if that's where we're swollen, we've got a little bit of soft tissue swelling here as well. Again, don't rule out the dew claw because it's a source of lameness that we see. And it's nice to diagnose because it's quite easy to treat with cortisone inside the joints, so inside the tendon sheath. So look for that, look for the little things. So again, an elbow, just to show you some other things, an immune, a destructive, a rheumatoid type, arthritis, again, could be mistaken for a septic joint. Tapping this joint's full of neutrophils, healthy neutrophils as opposed to toxic neutrophils as a standard of a rheumatoid joint. But you've got real destruction going on there. Often the septic joint will be arthritic, it'll be more proliferative than destructive, as in some of these arthritis. We talked about hypertrophic osteodystrophy before. Initially, we had the ghost physis. That disappears as the trabeculae collapse. Eventually, they get replaced by this more florid pattern of periosteal reaction secondary to inflammation, and they can occur through multiple parts of the bone. Again, these are just an example of what you might see in some of these cases. So again, the young Great Dane, 6 months of old, lame forelimbs, swelling around his distal antebrachium. It's probably not an osteosarc. If he was 8, I'd be thinking that. But with that and that sort of pattern, this is the productive pattern. You've got new bone going on. You don't have destruction of bone. This is likely to be that at the end of the day. Very painful, very sore. But they get better. But they can have deformities that can change their growth plate, etc. Another example just here of multiple cartilaginous exostoses through multiple joints. Again, multiple limb lameness in a young dog. You can tell it's young because his apophysis here is open. His medial epicondyle is open in the elbow. So lots of things that can go on. Another Great Dane here with a little candlestick. You see this occasionally in dogs that are presenting lame, or they start to develop an angular limb deformity or shortening. This little wick here is cartilage. It's called a retained cartilaginous core. You'll see these on your x-rays as things come up. They may not be significant, they may not require treatment, but they require monitoring because you will see them on various x-rays. And as I said, this is a record for you that you've got, and these will be on the website, so you'll be able to see them all coming up if you need any references for these. So again, flattening of the femoral condyle here in a dog with knee disease is condylar OCD in the femur. So lots of things to show you, lots of things that you may or may not, but hopefully you'll see in your careers. So the art of radiography, I couldn't help it, I'd put something in. So now I don't know whether this is real or not, but I don't know, but it's interesting anyhow. So he's got a hell of a scoliosis, this person, so unfortunately, so. Fracture healing. I won't dwell on this for too long. I just wanted to say that bones heal. If you leave them alone, bones will heal. The body's response to fracture healing, to a fracture, is it's gonna heal. Our job as surgeons is to put it back together, to spatially align it, so it has a chance of growing. I want a joint I want a fracture when I put it back together, that the joint, if it's not a joint fracture, then when it has to be anatomical, I want it lined up, so spatially aligned. And there's different responses the body will produce. Now, if I had to choose a fracture, this is the fracture I would have any day of the week. So I wouldn't have the single cut across the bone, the transverse single fracture, because they're a disaster. They're an absolute nightmare, and it's all about strain. So when you've got multiple lines of fracture here, including up here, you have a low strain environment. So cells, osteocytes are a lot more resilient to having a low strain environment. And that's the principle of callus formation, of fracture healing. So regardless of how we treat this, and again, a double plate to hold it in, it's done. They call it minimally invasively. It's not. You're cutting a hole in it, so it's not minimally invasive anymore. But again, the less you manipulate these fractures in a low strain environment, the better it's going to heal. So locking it in position, putting some plates on, forget the fancy hardware. This is not what this is about. This is to show you that a bone, if we can stabilize it spatially, up and down and top and bottom, proximal and distal, will heal in this environment by forming a callus. And if all we need to do is line this up, and this is going to heal. But extraperiosteal callus won't always form that way. So say, for example, and that's a great thing to have, because we have a very stable environment just by lining it up. Looking at a plate rod, which is another technique of putting a frame together. This is a more transverse to short oblique type fracture that's been put in position with a plate to hold it. Again, it's spatially aligning it. No attempt has been made to put this fracture back together. But if this rod hadn't been put in, that's a fracture that's at high risk of failing. The reason being, you've got a single little piece down here that's very small. It's a concentrated fracture point, so there's very high strain in that environment. And so that's why I'd much rather have the other one, because it's low strain. I can fix that spatially. I'm fixing this spatially here again. But by putting a rod, which is just a pin, 30% to 45% of the medullary cavity in combination with your fracture repair, and I'm telling you some secrets here, consider that type of fracture. If you're plating it, put a rod in it. It's an IM pin. So then push it in and drop it down, because that provides a huge protection against bending in this case. And this is a very simple technique. It's a brilliant fracture configuration, and they work. They heal because you're protecting each other. So you've got load sharing by with the two implants. So this is another example. So, but still, this is a more stable environment, but you're getting a very little callus here. When you're looking at your x-rays to say it's 6 weeks down the track, this is not healing, there's not enough callus there, you need to ask yourself, well, what sort of repair did I have? What sort of fracture did I have? Is this a stable repair? Is it showing signs of repairing? It may not look like the one before, but that was a whole lot of fragments put together. The body's going to produce a bigger callus. In this particular case, and if you're looking at this, again, small callus tells me that it's a lot more stable. It doesn't have to produce that much callus to become more stable. So it can go from its hematoma to its fibrous tissue to its cartilaginous tissue to its bone as strain reduces, and that's how fractures heal. If you look at a TPLO, Craig must have done this because it's awesome. If we do a TPLO here, again, it's a very stable repair and a way of stabilizing the cruciate ligament. You have a single cut here, you have a very large metaphyseal surface area, you have a rigid plate in position. So this doesn't have to heal, it's stable with a rigid callus. And if I look at this down the track, 6 weeks, the fracture line's all but gone, but you've got virtually no callus. So again, just those three scenarios I wanted to show you, because I know people do fractures, is assess the fracture with respect to its stability. You don't need a big massive callus to allow this to heal. This is more direct bone healing. This is more more stable, but still it's extraperiosteal, it's producing a callus. That first one was a piece of jelly in there, like a perfect hematoma for healing. It's the best bone graft in the world, but it heals with a callus. Everything goes out the window with puppies. They all produce callus. So they go big callus-like and they heal. But that's what puppies do. They're bone-healing machines. In the syndrome, puppies should be more stick a puppy in a box, it'll heal, whereas cats are a little bit more difficult. But that thing applies to puppies. Again, just another example of what a fracture can do. It goes from an unstable fracture, not treated with anything. These are experimental studies. It starts to remodel. You get your extraperiosteal callus. There's nothing wrong with that. It's fine. The fracture is improving. It's consolidating extraperiosteally, and it's eventually healing. One thing to keep in mind is when you look at a fracture 6 weeks down the track, if you don't have a completely stable fracture, the fracture gap might look wider. Very common. The body says to itself, well, okay, what am I going to do to get this strain down to a very low level? The way that it reduces strain, instead of having that tiny little fracture gap, it will widen, it will resorb bone, and its fracture gap will become wider. That's the body reducing strain in that environment. So hematoma can go from fibrous tissue to cartilaginous tissue to bone. So don't be alarmed if you've got a dog that's got a plate in there and you've got a widened fracture line and you've got a fluffy reaction and it's painful, or he's pyrexic or his local nodes are up, that's probably something different. That could be infection. So it can do the same thing. So again, keep in mind what's going on with the patient at the end of the day. Fractures don't always heal. Here's a distal radius fracture that didn't heal, fractured through a screw hole. The screw hole up here, these are awful things, and that's where it repeatedly fractured. It got an infection in the screw hole. The fracture itself's healed just up here, but things happen. So ask yourself what's going on with this clinically. If we're doing x-rays and we do fractures or we do repairs and we see the same thing, you need to know what can go wrong. So the main thing is, have implants failed? Have they changed? This is an example here of patella luxation surgery. Mechanically, this is not, and there's no blame laid, whatever. This happens. The biggest thing I'm going to tell you is the reason this failed is your wire here is too small. The best thing I was ever taught was small pins, big wire. You've got to stop this pulling, the quad's pulling it up. So to put a too small a wire in here is the direct reason these pins have bent, because they haven't been able to maintain or counteract the pull of the quadriceps. So for anyone who's doing patellas, consider putting a cerclage wire in. Always do a trochleoplasty. Basically, virtually always do a tibial transposition. Consider a wire. There's papers out there that suggest that over 15 kilos, I think is it 15 kilos of body weight, put a cerclage wire in. It's an anti-tension, it's an anti-pull device, but the wire's got to be big enough to counteract that. That is just far too small, and it's gonna fail. You could have predicted that. Looking at other things, again, screws and joints. So we critiques of ourselves. We did this. If we did, we didn't, because we don't put staples in. But again, this is a critique of a screw going into the joint. What would you do with that? You'd do something about that. So you're critiquing yourself and you're managing that, because the last thing we want is joint fluid dribbling out of that into the wound, getting infection. So again, we're critiquing implant location. We're looking here, a dog that's not healing properly. You can see you've got widening of the joint space. This was an infection in here. It's got this irregular pattern. Its nodes were up. It's got joint effusion. So this was a septic arthritis with loosening. The other thing that makes me think there's something wrong here is I look around all these screws here. Oh, come back. If I look around all the screws there, you can see that black line around all the screws. That can be normal. On a digital X-ray, it's called the Uber-Schwinger effect. So I don't know what it means, but it means something, and it's Uber-Schwinger. But Mr. Uber-Schwinger maybe. So, or Mr. Uber was a Schwinger. I don't know. So don't know. So, but having that lucency around there, if it's only on one screw, I'd be more thinking this is a problem. Or if the lucency that's not even around the screw is uneven in different spots, it's more likely not to be this artifact that we see. But when it involves all 6 screws, then it's more likely to be infection. Premature loosening, again, pull out of screws with locking plates nowadays does occur, but it doesn't occur very frequently. It's more likely to be instability leading to infection. This is the example I told you about before, whereas a plate breaks. This is not a good fracture repair. So you've got a femur that's got no load because it's had a previous femoral head and neck excision up here. You've put a ton of screws in here, you've put a ton of screws in here, and you've gone into this fracture to play around with it, to try and pull these little fragments back together with little wires. Not going to work. It's just destroying the ability of this bone to respond quickly. And any fracture repair is a race against time before the implant fails. If you think of it like that, what am I going to do to make it stable enough for 6 weeks that it's not going to move, it's not going to change, so that I get some repair? So the more I go in and I muck around with that, I'm destroying the soft tissue attachments, which are the reason why these things heal. You've put implants in here. That's a scenario that, because of a small fracture gap here, it just almost, I'd say, has to fail. And this is what's happened through here. Again, one way, if you're looking at that scenario, and if I was treating that, I would put, firstly, I probably would use a locking plate nowadays, but if I don't have a locking plate, I would probably put 3 or 4 maximum in here. I wouldn't go into the fracture. I wouldn't virtually never use cerclage wires in a fracture itself. And I would put a rod in this. If you don't want to put a rod in because you can't in this particular dog, what I would say is don't go into the fracture hematoma here and treat it that way. But you'll still get a rod in here that you can leave in here if you have to. The other thing you can do is double plate this. So you can put a plate on the back and a plate on the side and a plate on the front. So if I can do something to strengthen this up, that's what I would do, and put another plate on the front if I couldn't put a rod in. Now, the only thing I'd say about fracture repair is think to yourself, again, it's a bit of a digression, but I like to digress, but dealing about fractures, ask yourself, is this fracture 100% anatomically reducible? To me, if I've got a fracture that's long oblique, for example, and I can put it back 100%, put it back. Reduce that fracture. Cerclage it if you want to, if you're following the principles of cerclage. Lag screw it, so you're creating a bony column again. Then you need less of an implant in there to protect your repair. You've got a load-sharing environment between a bone that you've reconstructed anatomically and your implant that's protecting it. On the other side of the coin, if you can't 100% reconstruct this fracture, it doesn't matter what it is, don't even try. Because if we leave a little piece on the medial side, on the transcortex there's your high strain. That's when it's going to fail. So you've got to put it back together, or you don't at all. You go from carpenter to biologically and treat it that way, thinking and knowing out where it's going to fail. If you're putting a rod, like a interlocking nail, right down the middle, it doesn't matter. But none of us have interlocking nails. So, well, I do, but we still don't use them very often because the plate rod is probably, I'd say, probably our go-to still for a lot of these fractures because it works. Or if you're concerned with this scenario, put a rod down it. Put a pin. Any pin over than 30% or 25 to 30% higher will protect these fractures. So I better move on. Sorry about that. So, right. Some normals to look at. We've looked at a whole lot of things. We've looked at bone responses. We've looked at how I approach an X-ray, what I like to do to sort of not miss anything. And it's just a simple system that you follow every single time. It doesn't matter what it is. But try to get, if you're taking X-rays to interpret, try to think about how am I going to maximize the information I want to get out of this patient. The beauty is, if you can do good X-rays or improve your X-ray technique, you're going to have a better diagnostic yield potentially. So the normal stifle. So this is a normal stifle in AP. Now, normally we would line it up in a extended position. So the landmarks I use, obviously spatial alignment between here. Really nothing to look at through here from an immediate spatial alignment. But what I want to see is a patella ideally centered. But in a patellar luxation, that's not going to happen. So I have to look at other landmarks. And the big two things I've got here, I'm going to come right up here. See these lines here? That is a sclerotic line of the intercondylar notch. If they need to be parallel, if you're parallel, your stifle is in a true AP. So your knee is sitting in a true position. So I look at that first. That is my goal, to line those up so they are parallel. If they are rotated, this white line there and there won't be parallel. They take on a curve and they won't be parallel. So that's my sole landmark, because I'm saying I'm looking at the knee in this dog. I want to look at the femur, obviously, but I use my knee as a landmark and then work back. If there's a torsion or a twist in the femur, you soon work that out, because you put the knee in position and the leg's rotated. So you soon can work that out. But from a knee point of view, from what a lot of us are doing, that's how I line that up. From a lateral point of view, again, these are orthogonal views, not very well coned, and not very well collimated. Again, not something I advocate. Keep it as small as you can around the knee. We should have the condyles overlapping here, so you can see the unicondylar sign. One condyle, that's all you want to see. Now, it's sometimes bloody hard to do it. You take 6,000 x-rays and you still don't get it. But that's our goal, to have the perfect x-ray, or as close to it as possible. There are little ranges and adaptations, and I'll show you a few going through. One thing I would say, again, another thing here, that's all lined up. See how that's all parallel through there? This is the same dog. So this dog's got nice fascial line down the back. He's got a nice triangle in there, black triangle. So he doesn't have any effusion, but this dog came in for knee pain. Can anyone tell me what's going on with this dog? Yes. So grabbing the femur, grabbing the tibia. He's painful. He's full of panosteitis here. So again, on the edge of the film. Look at the edge of the film. Check it. So the knee doesn't matter. Beautiful x-rays, but it doesn't matter. Hasn't got that. So he's not having a TPLO today. So some of the abnormal things we see in the stifles. So looking at, again, lumps and bumps, fragments of bone, etc. There's only a few things that can break off. In a young dog under a year of age, was running around the beach and he went lame, and a Labrador, 6 months, he's gone and lame with knee effusion, knee swelling, he's had no issues at all. The likelihood he's got some sort of traumatic injury going on. And looking at this, this is this dog here. He's got a cruciate ligament avulsion. He's got effusion in his joint. He's got the fat pads. See how the fluid's bulging out the back here? You've lost this fascial line. He's got a fragment of bone here, little fragment of bone here. So this was a cruciate avulsion. Again, back to the young dog at the beach playing, breed that's predisposed to it, and that's what it was. Another case here, a young large breed dog, again been chronically lame. Maybe he was 6 or 9 months old. I'm just making this one up because I can't remember. 6 or 9 months old with some chronic lameness, with some knee effusion, and pain in the knee itself. Lateral x-rays. And this is a good example whereby the soft tissues are not present. Because the soft tissues are not present, I can't see what's going on inside that joint. If it was more columnar, if it was the soft tissues were more balanced, so the contrast was different, you'd probably see effusion there. This is a piece of bone, a fragment of cartilage that we can see on the x-rays here. So this is osteochondrosis dissecans, or OCD of the knee itself. Again, an odd spot. They're usually underneath, but you get the odd one through there going on. Other examples, avulsion of the superficial, the fibella, off the superficial digital flexor and gastroc tendon. It's dropped down, should be sitting up here in a cat. But again, a cat, no effusion going on inside there. So that's another healthy cat. Remember, patellas in cats look completely different. The way you treat patellas in cats surgically, completely different from dogs. Principles are the same. You need to move the crest. You often need to do a patelectomy. Again, just a little bit of advice. You have to do a sagittal patelectomy along with a groove to get cats with the patellar luxation to fit in. But again, just an example. One other thing that you will see occasionally, this little bone here is called the popliteal sesamoid, and it should sit at the level of the caudal part of the tibia here. If this was dropped down here in a dog, I'd be thinking, well, what's going on to make that piece of bone move? It's an adult dog, it's been running around, it's traumatic, it's got lateral knee pain, and it's got a dropped popliteal sesamoid. popliteus avulsion. Again, back to anatomy. Again, back to the clinical picture, combined with the X-ray picture. So occasionally you think, well, I've got a knee problem, I can't work it out. I will use my X-rays to help me with diagnosis, but I've got a clinical suspicion that we've got a knee problem, there's something going on that makes me want to move forward from there. And again, we all see these things. So a lytic lesion crossing the joint, going through here, involving both joints, a pocket here. So this was a histiocytic sarcoma in the joint of a St. Bernard. Again, effusion, loss of the fat pad, bulging of the soft tissues, fluid inside the joint, out the back. So again, just another one here, something different. Long digital extensor avulsion, Great Dane injury. It's virtually the only breed you see it in, but large breed dogs. So again, fragments inside the bone, they come from somewhere. Occasionally, cats will have mineralization of their cruciate ligament. Old cats, very common, very incidental. Occasionally will interfere with extension if they're big enough, but again, something you will see, a mineralized density within the joint. It doesn't always mean it's a problem. Again, if you've got and often you see them bilaterally, you've got a cat with no lameness, has got hippo A or something, you'll often see these on X-rays in cats. So don't be alarmed if you see them. Base it on clinically what things are looking like. So the abnormal stifle. So one other thing I want to say is effusion is not always present in these patients. So this is a dog here with a partial tear of the ACL. This is a dog with a chronic tear of the ACL. What I can see in this joint here is everything is smooth. The outline of the bone's very smooth. The outline of the joint is smooth. There's no osteophyte that you'd expect in a joint that's remodeling and degenerating. There's very little effusion, but there is this little wisp here of early fluid building up. In a dog that's got knee pain, he's stable, and the stable joint always means it's a cruciate. So if you've got effusion, you've got pain, but he's unstable, do not rule out cruciate disease, because partial tears are very common. This is how they start. They start as a partial degenerative tear. They progress to chronic tearing, and all these changes that we can see starting... Oh, where's it going there? Hello? Oh, looks like it's... Oh, it's back. So all these changes with effusion, osteophyte formation around the trochlear ridge, around the fibella. Again, this is the early stage of that. Cruciate disease is a progressive degenerative disease, so it's always going to start there and it's going to go to that. It's just we happen to see those early cases, and they're the ones to treat. If you can get them early, you've got a healthy joint. It's not healthy, it's healthy, rather than bad. So treat it early if you can see them, but just because you don't have an effusion, if you've got knee pain, you can rule out other things, so the OCDs and things like that you won't see in a young adult dog, generally over a year, then don't rule out cruciate disease because we don't have an effusion. One other thing I'd like to say is patella luxation. Patella luxation generally will not have any effusion. So an uncomplicated patella in a young Yorkie or whatever, a terrier that doesn't have an effusion, has an uncomplicated patella, treat it as a normal patella. If you've got an effusion in these dogs, there's something else going on. He's either, in most of the cases, in the younger dogs, they usually have chondromalacia. So they have an ulcer basically forming on the medial trochlear ridge, most of them are media. You have a maltracking patella that wears through the cartilage, exposes subchondral bone, produces cytokines, etc. Then they develop an effusion. So your suspicion for something else going on is heightened when you see an effusion in a patella dog. The second thing that you see effusion in is if you've got concurrent patella luxation and cruciate disease. So look for cruciate disease. Look for cruciate disease in chondromalacia. So you see a nice red, pink oval whereby you've lost the cartilage. So you have to have full thickness cartilage loss generally to develop an effusion in a dog with patella luxation. Look for steep tibial plateau angles. Again, 53 degrees. So that tells me that it's 37 degrees of tibial plateau angle. Many dogs are 25 to 30 degrees. But one of the reasons why these progress to that is their angle is too steep. So just something to look for. I can show you how to measure TPLO angles, I can show you how to measure TTO angles, or Craig can do it, depending on what you do. So better move on, sorry to digress. So shoulders, normal shoulders. The lateral view to me is by far the most diagnostic view. The biggest thing you need to do is get rid of the soft tissues, overline it. So this is a no-no here. If you've got this x-ray here with the trachea, overline, the ribs are out of the way, but if that's lying there, that is not a diagnostic x-ray, because you get gas formation or the appearance of gas, you get artifact, you get composite shadows over the top. So it ruins your chance of getting an answer. That's what I want to see. So I want to see the trachea out of the road. And the simplest way to do it when the line on their side, I keep doing that, when the line on their side is just pull the arm, the forearm out of the road. So, and get someone to pull on the front leg and get that trachea out of the road. So if you've, I would start again and say, like, let's just pull it a bit further and get the trachea out of the road. And that provides a nice contrast of the shoulder joint. So the shoulder joint should have normal anatomy with respect to the scapula. We always look at the back here, just check the spine at the same time, make sure the density's right, look at the joint spaces, the discs, etc., make sure they're fine. But you should have a normal alignment and a nice curvature of the humerus looking through. You're looking for, obviously, medullary, cortical lines, making sure they're all okay. Again, don't do that. And then this is a hard view to get. Normally you pull them out in front, sometimes you've got to put them down by the side, but that's a hard joint, and again, it doesn't give me a lot of yield unless you've got fractures, unless you've got tendinopathies or mineralization in here. Often we see x-rays whereby the scapula goes there and the humerus goes there, so you've got this angulation. It's an artifact in most cases, so you don't have a medial collateral injury. It's a very mobile joint. It's very easy to create an artifact, but if you extend them out like that and pull on them, if I put the ideal way is, if you don't want to hold them, is put a rope and a sandbag over the edge of the table and pull them out that way, so you have a no hands held. Often, unfortunately, in Australia it's easier to hold them, and I'm afraid we do in some cases, probably too many cases, but it's done in the UK, it's an absolute no-no, so you have to be very careful at positioning your x-rays, which makes you good. So things that we see in the shoulder, just abnormalities, again, this nice curvature of the shoulder here is gone. You've got this flattened ridge here. Again, you're in a young dog. I can see the growth plates are open. The supraglenoid tubercle here is closed, which closes at 6 months. But that's OCD, so that's a fragment of cartilage that, because that is a thickened piece of cartilage, you can't see it on an x-ray. But because the bone is going up and the cartilage hasn't formed a thin layer, it drops off. So that's why we see that flattening of the caudal aspect of the humeral head. One other thing, always check the other leg. Always take the x-ray of the other leg, because this is what you see. There's another OCD fragment through there. This is the mineralized fragment that's broken off at the back here. Again, just signs to watch for. So you've lost this nice curvature here. Now again, this is not a good x-ray, but fortunately in this case it told me, you can see here, this is not my x-ray, but this is an avulsion of the supraglenoid tubercle. The biceps tendon comes down here, right through the medial, on the medial side of the shoulder, but again, that's not normal, so that's an avulsion. So just some of the things you might come across. Fragments here that you'll sometimes see on shoulder x-rays. So fragmentation of the accessory process of the caudal glenoid. Corgis, it was traditionally in the UK that we used to see this in, young corgis or chondrodystrophoid breeds. That's a fracture inside the joint. There's a growth plate there, but it fails to fuse on. One other thing you'll see is mineralization through one of the areas of the front of the shoulder here. That on its own, I can't tell you what it's coming from. If I did a skyline view, for example, I could then tell you that this is where the supraspinatus inserts. The biceps tendon is down in here. So I know that mineralization here is in the supraspinatus tendon. Again, it's a very common finding, but it usually reflects intra-articular disease if you see that. Nowadays, realistically, we would CT these to get a better idea. Rather than these skyline views of the intertubercular groove, we would CT them. But again, it can and has been described as a primary process of degeneration. Seen in humans and dogs, it usually reflects collateral ligament insufficiency in the shoulder joint. But just an observation, something to direct your findings. But again, they can be uncomfortable to push on them. So you think, well, it's a primary tendon disease. It's often, if you manipulate the shoulder, you will get non-specific pain in there. So just some of the findings you might see. Now, one of the big questions we get a lot is elbows sent to me. So the elbow, the normal elbow. People, and we come back and say this dog's got subtrochlear sclerosis, which is the most important radiographic indicator of elbow disease, or medial compartment elbow disease, elbow dysplasia in a nutshell, basically. So what we're looking at is the condyle of the humerus. There's only one condyle. It's divided into two parts, but it should be overlapping. So this condyle here should be overlapping in a nice lateral. It can be a 90 degrees, a lazy lateral. You don't have to force it right up. So the elbow scheme doesn't require them to be flexed up. You can still see the anchoneal process, which is realistically the only reason I would flex them right up. You don't need to. So what we've got here is the medullary cavity, and I'll just see if that works again so I'm not jumping across yet. No, there we go, it's back again. So the medullary cavity comes up here of the ulna, and it should run with a slight deviation across here. But you should have a triangle here in this point. That is the medial aspect of the joint. See the trabecular pattern in there. That's a normal elbow, is what I want to see. Now, in the AP, see, that's just on the edge of the film. As I said, look on the edge of the film. See how that's deviated. There's nothing wrong with that shoulder. It's just that's what the shoulder does. It doesn't have a ligamentous problem because it slides over the top. But this is a normal elbow, so it should form a nice sort of shape whereby the widest part is here, and we've got the radius just sticking out laterally in the medial side of the joint. That's a good elbow for me to see. But this is often the part that we're looking for. So if I come back to you and say, this dog's got sclerosis, again, well shown to be consistent with mechanical overloading of the medial side of the joint. So I put this normal here again for you. This is a normal elbow just to see here. Again, the medullary cavity comes up. It almost goes in a straight line, little bit of a chamfer here, but you can see the trabecular pattern. Look at this thing here. That's what I'm looking at. That is trochlear, that is sclerosis of the distal aspect of the ulnar trochlear notch. That is where, on the medial side of the joint, that's what we call sclerosis. So you can also see this change in density in the medial coronoid process through here, and we have a congruent joint that you can see on an X-ray. So that's sclerosis. If anyone's not sure, you see that in a dog that's got pain on medial joint line tenderness, so pressure on there, flexion of the elbow, internal rotation with pressure on there. This dog's in a 6-month-old Labrador that's uni or bilaterally lame. He's probably got a component of elbow dysplasia in some way, shape or form. But that's the definitive test. They call it the Campbell's test, but that's what's going on. Again, you can see osteophytes forming here. Again, other little non-specific findings that we see. Radiographs are a very poor correlator as to the severity of disease. You see dogs who've got virtually pristine elbows, but they're painful. You can see dogs with osteophyte formation back again through here. So looking at the medial aspect of the humerus here, you've got osteophyte, you've got remodeling of the radial head here. This is a slightly older dog. You've got this narrowing through the medullary cavity. Sorry, it's just not sitting very well. And you've got this white sclerotic area there. So that's, again, the very classical features you would see of elbow dysplasia in that location. And then you have your osteophytes up on the anchoneal process up through here. So they are the traditional things that we look at. Again, this does not correlate. That could be more painful than this. And so radiographs, as I said, don't correlate with that, with the degree of lameness. Anchoneal process, it's ununited. Again, you've got the short ulna that we talked about before. The ulna's down here rather than up here in line. The pressure that the radial head pushes on the anchoneal processes causes this to separate. So that's a slightly fixed, but not a fully flexed. And you can still see there's a line here. So if by 16 to 20 weeks it's not fused, that process there on your X-ray, it's regarded as ununited. So 16 to 20 weeks is about the cutoff. It should be united by then. It's a separate apophysis. It's a separate center of ossification that should unite. So if it doesn't unite, it's ununited. So again, same thing here, looking at this. Again, we've got this little sclerosis here. We've got the shortened ulna. through here that is pushing on the ulna, the ankylosing process. This hasn't separated, but it's caused by an abnormality down in the growth plate. So you look at the whole antebrachium. You also got panosteitis in this dog. So one quick thing about elbows, old cats. So moving on. They look like they've got arthritis. They may or may not have ulnar nerve deficits. They may not have any nerve deficits at all. They have medial pain. This is feline medial epicondylitis, and it's not uncommon. So always look at the pathway of the ulnar nerve, because these osteophytes that form will trap the ulnar nerve, and it's not uncommon. So in any old cat that's got a forelimb lameness with elbow pain, that's what I'll be looking for, because this is potentially a curable disease. The ulnar nerve becomes trapped on the medial side of the elbow by osteophyte, by fibrous tissue, by the flexor carpi ulnaris. You can release that, and these cats will get better. So just something to look for. In an old cat, they're usually older, 10 years plus, with forelimb lameness, with elbow pain. Again, it's a surgical disease that can have high success rates. So hips, I'll move on very quickly for you. We've talked about hips again, orthogonal views. I want to see a set of hips lined up. So a set of hips should involve both limbs parallel, knees are centered, they're lined up nicely. You've got even overlap between the ischium on both sides. But a very simple thing to look at are these two holes here, the obturator foraminae. These foraminae should be symmetrical. They should look like eyes, basically, and they should be the same. So when I look at the head, and again, just another example of a younger dog, same thing. We've got these two eyes lined up. If you look at the alignment of the spine here, again, the dorsal spinous processes should be right down the middle, but again, everything's lined up here. If I look at these two eyes here, and I look at the heads of the femur, they're round. And so one of the comments I get is, does this dog have hip dysplasia? But I get an x-ray a bit like this. So this dog doesn't have hip dysplasia, but he has flattening of the roundness of the femoral head here. And that's where the fovea capitis, or the acetabular ligament, the teres ligament, not the acetabular ligament, goes in. So because we have an x-ray that the eyes here are not even, you can see that one's wider, this one's more oval in its presentation. So that's rotation. I can also see up here the spine is rotated, but this is the giveaway. And the reason that these flattenings occur is we're just catching the teres ligament at the head of the femur, and it looks dysplastic. This is not a dysplastic hip. So the tip I can give you, if this is rounder, and this is more oblique in its more oval in its presentation, this is the bit that's down on the table. This is the bit that's higher. So you want to lift this side up. So the bit that's rounder, lift that up, and that will correct. You've got to play around with it till it's correct, how far you rotate it. And sometimes it's quite surprising. But ultimately, I want to end up like that. But at the bit that is rounder, the obturator foramen that's rounder, lift that up, not down. And that'll help you correct your alignment. So, okay. Hips abnormal. Obviously, we see lots of hip dysplasia. These are called luxoid hips. So again, a take-home message. These are not dislocated. This is not traumatic dislocation. This puppy was born normal, and then he developed these hips. So these are hips that are right out of position, and ultimately they will become some cases they become a problem, but the femurs will irreparably remodel fairly quickly. Many of these are actually painful. So these are candidates, if they're painful, and it's a completely different discussion for hip replacement. But again, it's not a discussion we're having tonight. Watch for capital physeal separations, as you can see. Check the other side, as we talked about before. They can happen. So this is a physeal slip through here. Again, anatomy, this should line up. The growth plate is slipping. This is a case we all see every now and then. So Legg-Perthes disease in the young dog growing up. Again, they can present very differently, but that's what they can look like. So these are the things we're looking at. But it's a young toy breed. It's 9 months of age. It's got hip pain. It's that till proven otherwise. Or it's a young dog, bigger breed. It's physeal separation till proven otherwise. So common things do occur commonly, very commonly. So one take-home message about hips. Hips, and what you see on an X-ray is very, very different from what the clinical presentation is. I see dogs like this, for example, that look awful, and they've never had a day's lameness in their life. They might be a bit stiff, they might bunny hop, I don't care. If they're not painful, if I can't get them painful on their range of motion, and I'm looking at a dog out there running along, I look at where he's moving and what his accommodation is, what his quality of life is like. So all these questions that have been asked, has your dog ever been lame? No, but he walks funny. But I'm not going to go into a patient and start saying, I'm going to rip his hips back, when his accommodation is a bunny hop. He bunny hops for a reason, so he doesn't have to flex fully, he doesn't have to extend fully. So me coming in and graunching his hip saying he's got hip pain doesn't apply, because it doesn't fit with his clinical presentation. But if I do a Barden's hip lift on him, for example, if I give him a range of motion, then lift his hip out using my hand as a fulcrum under his thigh, and then I pull this out, and he's not painful, and he's bouncing around as a happy Labrador, no worries in the world, then who cares? He's accommodated, so he's not a candidate for treatment. On the other hand, On the other hand, if he's got this scenario here as a youngster, on the left-hand side where he's got minimal to mild change, but he's painful, he's a young dog with juvenile dysplasia developing, he could go on to this, he will go on to this radiographically. But if he's a young dog with laxity, with minimal change in his hips, these are the dogs that are painful. So juvenile dysplasia, they are painful. If they're going to be painful, that's often when they're painful. They're often not painful when they're adults. So look at the young dogs. Pain is a feature of mild subluxation, of trabecular damage to the acetabulum. These are the dogs that are often painful. But many of these dogs grow out of that, and they get to this stage by 2 years of age. I'd say at least 50% are non-painful. A very old paper said 76% or something like that by Hamish Denny in the 80s. So conservatively managed dogs. So don't look at that and say this is a problem. Look at them clinically and say to yourself, well, is this an issue? Is this affecting the dog's quality of life? Would me treating it improve or change his quality of life? And if the answer to those questions is no, then we don't touch them. But don't be fooled by that. That is the body doing what it's supposed to do. It's producing a flared joint. It's trying to increase surface area to take away this tight, painful joint. That's what it's doing. But don't get me wrong, it can be painful. But I'd say more often than not, my first question is, what are its knees like? And very, very commonly, again, I've used that word a lot tonight because common things occur commonly, they do occur. Knees are very common, very, very common. The other thing I don't want you to forget, and we talked about then, this is my last slide, thank you, we don't want to miss the whole limb itself, the digits, the toes. Craig's written a paper that's in hopefully publication soon on sesamoid disease. So sesamoids, as we all know, are the little bones on the palmar and plantar aspect, inserted in and around the flexor tendon, attached to the knuckle bones, to the metacarpo and metatarsophalangeal joints. They are very commonly inflamed, angry. We see sesamoiditis in medium to large breed dogs, young dogs, but there's also a population of older dogs that we see. So they often lose, they come in, they're not walking right, but often you look at their toes, they maybe look a bit thickened or they've lost flexion. They can be painful. So as part of your exam, don't rule them out. So if you've got toe pain, saying that from Craig's paper, 50% roughly, I think, of dogs had elbow disease. So it's a lameness that comes on probably through mechanical means. We use cortisone to help some of these dogs. Does it make a big difference down the track? It probably speeds up the resolution from what we can find. Maybe it doesn't make a difference down the track, but again, watch for sesamoids. And if you look on an X-ray, which is my message here, sesamoids 2 and 7, so 1, 2, 3, 4, 5, 6, 7, 8. It could be the other way around. This could be 1, 2. I don't know, because I need the carpus to check. But sesamoids 2 and 7 or 7 and 2 are often broken up into pieces. And that is completely normal. They're not fractured. They are multipartite sesamoids. So they, as the ossification centres start to coalesce in the sesamoids, they don't form properly. But again, very common to see. They're incidental. They're not necessarily a cause of lameness. But if that joint is painful, associated with flexion, pressure on the sesamoids directly, again, take it in light. You do see sesamoid fractures, but again, it's usually a single digit. They're not thickened, they may be swollen, they're often traumatic in their event, but in a chronic lameness, sesamoiditis is common. Probably associated with other things as well. So again, scrutinise those elbows. Now you know what to look for in sclerosis. In a young dog, look at the elbows. Again, as I said, you see them pretty commonly. Again, keeping an open mind. So in this dog here, up the top here, we've got fragmented sesamoids there and there. The rest of them are normal, but we've got the swollen bone here, and it's an old Bristol thing, but a DEXA gamma scan here, scintigraphy, showed an osteitis in here. So again, just because these are here, this is a good example that other things do occur. And then just to end, you see these arthritic joints. Maybe they had sesamoiditis, maybe they're painful, maybe they're subluxated. We all see those dogs that are turned on their side, that are walking sort of with their toes twisted sideways. As part of this, they lose the integrity of their collateral ligaments and they start to collapse. And they can be painful. They can be painful. So again, just something to watch for. Again, these little two things here. So you see lumps and etc. But if it's not broken, we don't necessarily need to touch it. So I think my take-home message for tonight, you've seen a lot of slides and hopefully a few different things that might be new to you, is treat the patient. Look at the patient. This is about where is this dog lame? What's his problem? Is the problem that you identify, such as hips, for example, affecting his quality of life? If it's not, and we scrutinise the owners, and it's become very common now to ask the owners for videos of what's Fluffy doing at home. Send me a video so I can see what's going on. It's just a very useful tool that's come of age. So treat the patient. Don't treat the x-ray. Forget the x-ray until you've had a look at the patient. Sometimes it's hard. We have to do our dog in catagram, and for example, in trauma, for example, and for many other reasons. It can be a very useful technique, but if we're specifically trying to localise or isolate a lameness, it's nice to have all the information such as collimation, looking at the soft tissues. Just look at what's happening. It's bone and soft tissue. It's not just bone. Soft tissues give us a hell of a lot of information about what's going on elsewhere because they directly react to what's happening in that limb. The other example would be spinatus atrophy that we see here. If I can't work out a forelimb lameness, or I'm thinking maybe it's equivocal, or is it left, is it right? Just stand behind the dog and run your hands down its shoulder blades. Feel the spine of the scapula because the body reacts by, if it's not been used, same as a cast, put on our arms, it withers away, maybe slow, but you'll often pick up little things like that. Check the gluteals as I come down the back and I feel the back muscles. I'm checking for change in symmetry of the back muscles. I then come down the back, I check the gluteals, are they symmetrical? The quads, the hammies, all the way down. Extensor carpi radialis through here, cranial tibial for different nerve and lesions. So the muscles and the soft tissues give you a hell of a lot of information, and then we use our x-rays to back stuff up. And I think to me, it's a good approach to have. It gives us a lot more information, and hopefully they're just tools that we can use to take home and use in your practice. So, but that's all I've got to say because I'm out of breath. So. Oh yeah, count your swabs and your instruments. So it happens not just in us, but again, looking at that, and this is a real picture. So count your swabs. I'd say if you're doing a lot of belly surgery, have your markers, have your radiographic markers. Count your swabs in, count them out. I'm talking now because I'm a surgeon, but count them in, count them out, count your instruments, and just be accountable for everything because no one else wants that to happen. But if you use radiographic markers, if you're not sure, take an x-ray because that's where it'll be. All right, and thank you for all of us from the team, and thanks for everyone for coming along.